Welcome everyone to the MSRA Masterclass, Higher Revision for the MSRA 2024. So in terms of the format, I'll start with an overview of the exam and how the different specialties are going to use it this year. There's some changes for 2024 entry. Then we'll do exam style questions. So the main session, we'll practice some clinical questions, some SJT questions, so that we can see what they're like, but also hopefully I can highlight some of the important bits of exam technique and how to prepare for each of those. Then we'll look at, once you know what resources to use, revision planning, how to actually succeed, what separates those that do really well from those that don't do quite well enough maybe to either get a job or to get their first choice job. Because I don't want you just to pass, I want you to get your first choice job. So let's start with an overview of the MSRA. So the first thing is, this is not a standalone exam. You can't just sit the MSRA for the sake of it. It's an assessment used for recruitment by 12 different specialties. So you'd need to apply for training via Oriel, and you need to have your application accepted and longlisted before you get an invitation to book the MSRA. You can't just book it. So round one's already open. The applications close on the 23rd of November. Round two, the dates haven't been confirmed yet. Usually, though, the applications open in July and the MSRA is in September. Okay, so round one, remember, is for jobs to start in August 2024. If you're longlisted, you'll get an invitation to book the MSRA. They're expected around the 14th of December. Okay, and then the actual dates where you can book the exam, the dates, you're going to book a slot somewhere between the 4th and the 16th of January. You'll be able to pick the date that you want and the location that you want based on what's available. And there's venues all across the world at Pearson VUE test centres. Just in the UK, there's over 150 venues. Okay, so in terms of the format, the whole exam lasts 2 hours and 55 minutes, including the 5-minute break for those with standard timing. For those doctors who, for example, have got dyslexia or some other form of neurodiversity or additional learning needs, as long as you submit the proof at the time of application, you'll get additional timing. So usually it's 25% extra time. So it's all done on computer, and there's two parts. The first paper is always the professional dilemma or SJT paper. That's 95 minutes. Then you've got a 5-minute gap. Then you've got a 75-minute clinical problem-solving paper. Now, these are two separate papers that you do on the same day. So let's say you finish this one 5 minutes early. You can't have 5 minutes extra for this one. When this one starts, you'll still only have 75 minutes. The timing is separate for each paper. And there's multiple equated test forms. So, you know, when you click start, it will randomly allocate you one of many different versions of the exam. They all have the same proportion of questions from different curriculum areas and difficulty. That's why they're equated. But like even the person sitting next to you might have different questions too. And this is so that, you know, because it runs over nearly 2-week period, if it was the same exact questions every day, people that start it later might find out some of the questions. People might feel they had some kind of unfair advantage. And it doesn't matter which specialty you're sitting it for, the curriculum's the same. Okay. For each paper, the mean normalized score is 250. So what happens is, let's say the average score for everyone sitting the MSRA for this cohort, for the clinical paper, is 76%. Then 76% will be equal to an MSRA score of 250. Anyone that scores more than 76% will get more than 250. Anyone that scores less will get less than 250. The same for SJT. Let's say the average for the SJT tends to be higher. Let's say it's 82%. Someone that gets exactly that will get 250. More than that, you get more than 250. Less than that, you get less than 250. So someone that got the mean score in the clinical and the SJT, they get an MSRA of exactly 500. Okay. So how will different specialties use your score? And there's some changes for this. Well, first of all, let's see what you all are sitting it for. Great. So as we'd expect, the most popular, most of you are sitting it for GP as one of your options. Okay. Over 60% of those that have joined today will be applying for GP. After that, the other ones that are really, really popular are core surgical training, anesthetics, psychiatry, CAMS, and radiology. Also anesthetics. They're the other ones that are really popular. And then fewer of you doing neurosurgery or nuclear medicine, fewer of you doing ophthalmology, slightly fewer doing emergency and obstetrics or community sexual and reproductive health. Okay. Now, in terms of how they're going to use your scores, GP, psychiatry, and child and adolescent mental health services, CAMS, all three of these, your MSRA is 100% of your rank. There's no interviews, there's no selection centers, there's no portfolio, okay? It's just based on how do you do in your MSRA. Nothing else matters. Once your application is accepted, all that matters, and that will determine your rank and your chances, is how well do you score. For obstetrics and sexual and reproductive health, the MSRA makes up 25%. However, for obstetrics, there is an option of getting a direct offer. So this year, the top 75 scorers out of everyone that sits it for obstetrics will be able to skip the interview and just get a direct offer based on having a fantastic MSRA score. For everyone else, 25% will be made up of the MSRA. The other 75% will be to do with the interview. But you can see the highest scorer with MSRA and interview, they'll be ranked 76th because the top 75 will get direct offers. Okay. Emergency medicine, it's 40%. Neurosurgery and nuclear medicine, 40%. Radiology, it's dropped. It used to be 33%. It's now 20% this year. For ophthalmology, in previous years, it was 20%. Now, this year, what they're doing is just using it as a shortlisting tool. So they'll just take the top 300 scores and they will basically be asked to fill in their evidence. And then of those above a certain threshold will go to the online assessment, the interview stage. And then whether they get a job or not will really be about those things, not to do with MSRA at all. It's just to get you there. But because only taking 300 and there's going to be 1,000 people applying, you've got to be in that top 300. So you still need a great score. Okay. Anesthetics, 15%. Again, you want to get a really good score so that you can actually get that interview. But once you're there, it's mostly about your portfolio and your interview. Same with CST, only 10%. But you still got to be amongst those top few that are going to get that interview slot in the first place, so you can show your commitment to specialty, do well at the interview, and so on. For all of these, because of how competitive they are and how many more people apply than there are jobs, while some of them is very few, very small percentage in terms of your overall rank, it's used as the main shortlisting tool. So you can see, like in radiology, although it's only going to be 20% for those that get to interview, the main thing it's used for is to pick who gets an interview. Okay. And so if I show you the competition ratios, it will give you an idea. Competition has increased hugely over the last 5 years. I've been tracking data since the MSRA started being used back in 2007, when it was only used for GP, and then a few other specialties, and then more recently, more and more specialties. I've been tracking data for every single year. But what we see now, if we look at the last 5 years, you can see for a lot of specialties, it's doubled or more than doubled. GP, for example, we used to get 1.3 applicants per post. Back in 2019, just under 4,000 jobs, about 5,000 odd applicants. Come to this last year, 10,500 people applied for GP for 3,935 jobs. Okay. Look at radiology. Used to be about 3.5 to 1. It's now nearly 9 to 1. The last set of data we have available, there were 3,000 applicants. There were only 350 jobs. And they only called for interviews 700 of those. So do you see, over 2,000 and something doctors will be removed from the process that apply to radiology just based on MSRA. So although once you get there, it's only going to be 20%, you've got to get a fantastic score to just get that interview call in the first place. Otherwise, you could have a fantastic portfolio. You could be great at interview. You're just not, unfortunately, going to get that chance to get that interview. And that's the same for all of these specialties, which are very competitive. Okay, you can see the competition ratios. Now, CSRH, right, is the most competitive, and it looks horrendous, right? 34 to 1. But one of the things, there were only 8 jobs last year. Okay, so that's why it looks so huge. 270 odd people applied for just 8 jobs. Neurosurgery, 255 people applying. There are only 20 jobs in the whole country. All right. Ophthalmology, 971. There were 98 jobs. So you can see 10 to 1. And what they'll probably do is they'll only call for interview about 300. So, again, the bulk of people will be removed based on MSRA scores. Okay. Down to, as I mentioned, the most popular specialty, GP, 10,500 people applied. And one of the things, historically, pretty much everyone that passed used to get a job. When you're getting this number of applicants, because some people will fail the MSRA, most pass. But if you pass, usually if you're flexible on location, you get a job. This year, there were a couple of thousand people that passed that were willing to take a job anywhere that didn't get a job. All right. So you can see that all specialties, the level of competition has gone up significantly. And some of them, as I said, more than double. But emergency medicine from 2 to 1 to 5 to 1. Radiology from 3.5 to nearly 9. Ophthalmology 3 to 10, tripled. Okay, if we look at 2023, and I expect more people to be applying. So I expect these numbers to go up again in 2024. So this is why it's really important that you don't just focus on passing. You want to focus on getting the absolute best score possible. Okay, give you an example. Radiology, a couple of years ago, just over 500 in MSRA, i.e. someone that was right on the mean, would have been enough to get you an interview. Then 2022, you needed 520 odd. Last year, it was about 540. I suspect this next year, if trends continue, you will need somewhere like 550 to get a shot to just get an interview at most of these specialties. Okay, the program. Let's go straight into some practice questions for the clinical paper. So the clinical paper, remember, 75 minutes. In that time, you're going to answer 97 questions. Only 86 carry marks. In every paper, 11 questions carry no marks. They're pilot questions for research purposes, but they won't look any different and they won't be marked or labeled in any way. So you don't know which ones don't count. You have to take all 97 questions seriously. There's two main question formats: extended matching questions, which come in sets of 2, 3, or more, and single best answer questions, which just a single question on its own. You may get a handful of questions that are in other formats. So algorithms, where you might sometimes have to drag and drop labels to match the relevant guideline. Multiple best answers, a question with more than one correct answer. Pick 2 of these that would be suitable for management of this patient. The level of knowledge being tested is the knowledge expected of a doctor who's in foundation year 2. It's harder than finals. They expect you to already have been practicing, seeing patients, completed F1 or internship, and be in F2 at that level, okay? But it's not membership level. But don't underestimate the exam, because it's not a simple pass-fail exam like finals is or like PLAB is. It's competitively ranked. You see, nearly everyone that sits MSRA passes, but the majority of people won't get an interview or won't necessarily get a job. If you want a job, it's about doing as well as possible. So what makes it challenging is that the curriculum's really large. They're not testing that you know everything there is to know about one thing. They're testing, do you have a really broad base medical knowledge, okay, at the level of an F2 doctor. So this is the curriculum. The questions in each paper are roughly in equal proportions for these blocks, i.e. there'll be about as many cardiovascular questions as dermatology, ENT, and ophthalmology combined. As many of these 3 specialties combined as peds, as many peds as reproductive, male and female, as many reproductive as pharmacology and therapeutics, as many of these as all of these: infectious disease, hematology, immunology, allergies, genetics combined. Okay, so this is the curriculum. You want to make sure that you've read up on and practiced questions for all of these areas before the exam. And so in terms of extended matching questions, they come in sets of 2, 3, or more. Within a given set, the answer options stay the same, just the question changes. But the way it's laid out, there's only ever 1 question per screen. So I'll show you what it looks like. You're going to have about 45 seconds per question. The way I'm going to do is I'm going to show you 3 questions, 1 set of 3 MQs. They'll move forward automatically. So just write down your answers at home. After we've done all 3, I'll then remind you of the question and I'll launch a poll. I'm not going to launch a poll and give you an explanation after each one, because if I teach you on the first one, it'll give you the answer for the second one potentially. So I want you to benefit from the learning. Here we go. You won't see me during this. I'll now launch the poll. I'll remind you of each question, okay? And then we'll talk about why the right answer, and why you might have got it right or wrong, so we can develop exam technique, okay? Here's the first one. So key things in this one: the patient's 55, that they're otherwise fit and well. The fact that the ethnicity for some questions is relevant, but given they're otherwise fit and well and they're 55, it actually doesn't really make a difference, okay, for this particular patient. But in some cases, the fact that their ethnicity is white British, that might make a difference, okay? Okay, great. So very interesting. There's a big split here. The most popular answer, more than half of you have picked ACE inhibitor, okay? And then just under half, about 40-something%, have picked calcium channel blocker. And then a very small number have either picked ARB or beta blocker, all right? So, but most popular answer is an ACE inhibitor. So correct answer here is C, calcium channel blocker, all right? And the reason for that, as I mentioned, the ethnicity is not important because he doesn't have any other illnesses, otherwise fit and well. Why have I mentioned that? Can anyone think of an illness that would make a difference? If he had a history of which condition, would it make a difference? Yeah, absolutely. If he had a history of diabetes, then it would change the answer, right? But given that he's not diabetic, then the age matters. So under 55, it would have been an ACE inhibitor for someone who's Caucasian. But because it's 55, the correct answer is calcium channel blocker. So this is the current NICE guidelines for hypertension. We're looking at step 1 when we're first starting a medication. They're not on anything, okay? You see, age 55, or Afro-Caribbean patient of any age, if they're not diabetic, then it's calcium channel blocker, okay? i.e. the right side of the guideline. Okay, so let's do the second one. I'll go through the key things in this one. So here, this patient's 60, they're Nigerian, and they've got diabetes. If you missed it here, there's a reminder, he's on metformin, okay? But it's written there, isn't it? He's diabetic, all right? So what's the most suitable medication? Here, the ethnicity is really important. The fact that it's Nigerian, really, really important. Okay. It's a really tough question. The correct answer here is ARB, angiotensin 2 receptor antagonist, okay, and ARB. Why is that? Same guideline, okay? And here, interestingly, the most popular answer was ACE inhibitor, followed by calcium channel blocker. This was the least popular answer of the 3 main options that people picked. That's because here, look, if your patient's diabetic of any age, if they're diabetic, the age isn't important. If they're diabetic, then they're going to start on an A-class drug. However, when your patient is Afro-Caribbean in heritage, whenever they need an A-class drug, whether that's here, here, or here, then you go to ARB first line, not ACE inhibitor. Whereas can you see here, ethnicity is important. This patient had been Caucasian with diabetes, then the answer would be ACE inhibitor. Because for most patients, when they need an A-class drug, ACE inhibitor is first line, and it's ARB if they can't tolerate an ACE inhibitor. Type in the chat, what's the most common side effect that makes patients stop taking ACE inhibitors? Dry cough, fantastic, well done. Yeah, okay. But here, this is new in the latest guideline. This wasn't in the old guideline, okay? That wherever Afro-Caribbean patients need an A-class drug, whether it's on this side or this side, you should favor an ARB rather than ACE inhibitor first line, because research suggests that they have better outcomes, okay? So that was important, picking that up. Okay, last one in the set. I'll launch the poll again. And I remind you, this patient's 41. We have no mention of ethnicity for this one. And that's because for this one, it doesn't matter. What's important here is that we've picked up high blood pressure at her booking antenatal appointment. Okay, antenatal, so she's pregnant. All right. No other medical history, not on any other medication. So what's most suitable now? This, in terms of exam technique, what does this keyword mean? Most suitable means for this patient in this situation. So for a patient who's pregnant with high blood pressure, what's suitable for that patient? Okay. And here, the correct answer is E, beta blocker. Now type into the chat, which one specifically? Yeah, fantastic. Well done. Labetalol. Okay. Now, well done. That was the most popular answer. 50-something% of you picked this. There was a big spread for this one. A lot of people picked A, few people B, C, D. Now, those of you that picked calcium channel blocker, because that was the second most popular answer, type into the chat, what were you thinking? Which calcium channel blocker were you thinking about? Okay, fantastic. So someone said nifedipine. See, that's actually not a bad option because nifedipine can be used. I'm going to show you another really important bit of technique, why nifedipine is not the right answer, okay? Because most suitable is a relative term, right? nifedipine is suitable, but it's not the most suitable. The most suitable would mean what is the first line in the guideline, okay? And here that would be labetalol, and that's why E is the right answer. So hypertension in pregnancy. If someone is starting treatment for hypertension, so they went already on medication, or if you were changing, for example, if someone was an ACE inhibitor or an ARB, that's not safe to continue during pregnancy. You change them to labetalol, okay? Labetalol is the first line. Nifedipine, which is a calcium channel blocker class, that's recommended as second line if labetalol is not suitable for some reason. Can you think of a reason why labetalol wouldn't be suitable? What kinds of things in the patient's history? Yeah, most important one would be asthma. The patient was asthmatic, and so you don't want to give them a beta blocker, then nifedipine would be the right answer. But because this is an unlicensed use, and this is a general principle of prescribing that's applied in the exam, that if you have two options that can both be used and both would maybe be effective, if one is licensed and one is unlicensed, the licensed one will be favored, okay? And then methyl dopa, which is a centrally active antihypertensive, that's recommended third line. If both labetalol and nifedipine are not suitable, they need to consider methyl dopa, okay? The key thing is that ACE inhibitors, ARBs, and thiazide diuretics are really not safe in pregnancy, not recommended at all, okay? And so do you see, although nifedipine as a calcium channel blocker can be used, it's not the most suitable. One, because it's second line, but two, because it's an unlicensed use of that drug in this condition. Okay. Right. And we're going to do a set of 2 EMQs on investigations. So that was looking at management. We're going to look at investigations now. Okay. So again, do the questions. You'll have about 45 seconds. It'll move forward, write down your answer, and then we'll go through it after. Here we go. Okay, so once again, I'll launch the polls. Here's the first one. I'll read through. So key thing here, this is a 70-year-old patient, and they've got dysuria, nocturia, and frequency of urine for 2 days. We've got some negative findings: not feeling thirsty and no blood in the urine. And this is actually a 2-step question. The mark is about the diagnostic test, okay? Ask for the most appropriate diagnostic test. So that means appropriate for this patient in this scenario to make a diagnosis. But it's a 2-step. The first step is to think, okay, what is it that we think might be going on here? So type into the chat, what if it asks for the most likely diagnosis? What's going through your head? Because in 2-step questions, the first step is very straightforward in MSRA. Okay, they're not trying to catch you out. Yeah, everyone's got this, right? UTI. Yeah, that's what we're thinking about. All right, you're not thinking about diabetes, are you? Not thirsty, and it's only been 2 days, it's not months. Yeah. So now, most appropriate diagnostic test, the correct answer here is B, urine culture and sensitivity. Now, I'm pleased to see most people got this right. Of those that didn't, about a quarter of you picked urine dipstick. Why is that not the right answer here? Because this patient is 65 plus, she's 70. And so, if you had a young lady, typical symptoms of UTI, low risk, uncomplicated UTI, you could actually diagnose based on urine dipstick, especially if both nitrites and leukocytes are there. It's more than 90% probability. We don't bother sending those for culture, we just treat them, okay? But it's got low reliability to diagnose based on the dipstick in certain patients, which is why to make a diagnosis for this patient, we need to do a culture and sensitivity. So let's look at that. In terms of suspected UTI, under 65, no risk factors for complicated UTI. You could use a urine dipstick to aid diagnosis. And, if, as I said, both leukocytes and nitrites are there, that's probably enough. You wouldn't even need to worry about going forward. But there are certain situations where that's not reliable. So 65 plus, women who've got a catheter, if someone's got a history of recurrent UTI, at risk for complicated UTI, someone who's pregnant, a dipstick's not reliable. You need a culture to make that diagnosis, okay? So, pregnant, persistent recurrent UTI, not resolving with treatment, or these groups, you need to send a culture. Okay, second one in the set. So this one, the key thing here is the age of the patient. They're 4 years old. They've got multiple UTIs over a long period. And when did their last episode end? That's really important. 4 months ago. So what's the most appropriate test? Again, remember, appropriate means for this patient in this situation. So the split here is between E and H. DMSA and abdominal ultrasound are the two popular ones, followed by KUB X-ray. Okay, that was the third most popular one. The correct answer is DMSA. So well done, that was the most popular, but 40% of you picked that option. Okay, so why is that? By the way, does anyone know what DMSA stands for? It's really difficult to say, isn't it? Okay, dimercaptosuccinic acid, DMSA, that's why we just call it that, right? So if we look at the guidelines, UTI in children 3+, this patient was 4. If they've got atypical UTI, during the acute infection, you do an ultrasound. If they've got recurrent UTI, this patient had many of them over a year, right? Then they'll have an ultrasound within 6 weeks. And then later on, you want to look for long-term damage. So they'll have a DMSA scan 4 to 6 months after the acute infection. So can you see? Because it ended 4 months ago, we're beyond the window for them to have that ultrasound. They would have already had it. What we need now at this stage, 4 to 6 months later, is the DMSA, okay? So it's picking up those small details that sometimes can, it's quite easy often to narrow it down to the last 2 or 3 options. Getting that last one often is small details. So exam technique, reading carefully, picking up these small things. Okay, so that's extended matching questions. We're going to look at some single best answers now. They have one question, common to have 5 options, but sometimes they'll have 6 or 7 options, okay? But let's do one with 5. Here we go. Now, another bit of technique here. The majority of questions in the MSRA are what we call positively framed questions. What is the right diagnosis? What's the most appropriate treatment? How would you investigate this patient? Which test should you do? Which side effects should you consider? You're looking for finding a positive, okay? But there will be a handful of questions in your paper that are negatively framed. You can see it says, which of the following would be least helpful in alleviating these symptoms? So, metastatic cancer, they've got severe nausea and vomiting. And we're thinking about a syringe driver. And so picking up that it's negatively framed, it's not asking what would be helpful, because if you miss that, you're not reading carefully and you rush to pick, oh, yeah, you know what? I've seen patients with syringe drivers and they've put this in because this mixed nicely with diamorphine that they might have, if they've also got pain. Someone with metastatic cancer might also have quite severe pain, right? Oh yeah, so I've seen that dexamethasone that can be used. Do you see? So if you miss that because you're in a rush, and it is time pressured, 45 seconds. That's how much you've got per question. All right, it's tight, right? It's easy to miss. So the correct answer here is B. Hyoscine hydrobromide is used for respiratory secretions or bowel colic in the palliative care setting. So given their symptoms of severe nausea and vomiting, this would be the least helpful. All of these other ones can be used in severe nausea and vomiting in palliative care. And so some of you will have had the knowledge, but missed that it was negatively framed because you missed this one keyword, least helpful. And you might just say, oh, which of the following helpful? Yeah, because you're in a rush. Easy to do. Don't worry you've done it today. Don't worry if you do it, if you're joining the full 2-day courses, because we will go through enough and you get the hang of really paying attention to these different keywords and picking it up, okay? And let's do one last one before we do SJT, okay? Here we go. Okay, so a couple of key things here. The fact that they're being treated for Lyme disease. So think about, could this be related to the disease itself, or could it be related to the treatment? Okay, so they've been given doxycycline, which is first line, and they started 12 hours after that. And then the actual findings: mild fever, facial flushing, bit of a tachycardia, and blood pressure 108/66, so a little bit on the low side. Okay, so this is the correct answer here is D, and well done. That was actually about half of you got this. So this was the most popular answer. There was a big spread of answers. A lot of people picked A or B. A small number picked C. Why is it unlikely to be C? Type into the chat. If someone was going to have an anaphylactic reaction, what would be the typical time scale from whatever it is that they've got a severe allergic reaction to? Yeah, it's pretty much immediate, or within sort of a few minutes to maybe half an hour. It's not going to be 12 hours after that they're presenting, okay? It would have happened much, much sooner than that, all right? And so that's, again, important, picking up this thing that is 12 hours later. But this is the Jarich-Herxheimer reaction, okay? So it can happen with actually any antibiotic treatment, but it's so common. If you look in the BNF, if something occurs in sort of more than 10% of patients, then we consider that to be a very common side effect. So about 15% of patients who've got Lyme disease that get antibiotics, they get this reaction. So it's very, very common, okay? Usually occurs within a day of treatment, and it's actually caused not because they're having a reaction to the drug, it's caused because the drug is working, okay? It's killing the bacteria, and that's causing a release of toxins, and that's why you're actually getting the sort of reaction that you're getting. So you get fever, chills, muscle pains, headache can get worse, but some of the additional features are important. Tachycardia, okay, vasodilation, mild hypotension, hyperventilation, okay. What other conditions can you see this reaction? You can actually get it in loads of things, okay, but probably the two most important ones beyond Lyme disease are syphilis and leptospirosis, okay. But there are various other things where you can get it, Q fever, brucellosis, but they're probably the two other important ones, okay. So in terms of how to prepare for the clinical, you want to do a balance of active learning versus passive learning. So active learning is like what we're doing, practicing questions, okay? Passive learning would be, for example, reading. Now, they both have their place, because if you do a question, if you get it right, you probably know enough about it that you've worked it out, or it might have been a guess. So, you know, if you fluked it, you still want to read up about it, okay? If you get it wrong, as well as reading the explanation in whichever question bank you're using, you might think, okay, the fact that I got that wrong suggests I might not have a good handle on some of the other options. And so to get a better handle on it, let me read up more about this topic. But the other thing is to make sure you cover the curriculum systematically, rather than just in a haphazard way doing random questions. You know, try to go through subject by subject and make sure you've covered all of the important subjects in the curriculum. Try to practice realistic questions, because that's going to help you work on your exam technique, both managing your time and picking up keywords. And then as you get closer to the exam, you want to build up your time management and your stamina by doing some timed mocks, okay? Remember that the questions are going to be related to one or more of these things. And some will be about investigations, some will be about making a diagnosis, some will be about emergency care, some will be about prescribing, and some will be about management that's not to do with prescribing. Some patients, for example, just need supportive treatment. Some need non-medical treatment, surgical or physio or things like that. So where to read up if you wanted to get a bit more detail about maybe something that you got wrong? Well, the Oxford Handbook of Clinical Specialties and Oxford Handbook of Clinical Medicine, between them, will cover all of the subjects in that curriculum, okay? The BNF, I'd recommend you spend a day on the BNF because there's quite a lot of questions on prescribing and therapeutics and pharmacology is one of the blocks, one of the big blocks. I'm not suggesting you try to read it cover to cover, of course. It's not meant for that. But at the front of the BNF, there's a good section on general principles of prescribing, pain management, and prescribing in palliative care. There are always questions on this. And then at the start of each chapter, there are a series of treatment summaries for the important drug classes affecting that system. The BNF is split into system. Drugs that affect the endocrine system, drugs that affect the neurological system, drugs that affect the skin, for example. That's a good, quick way to sort of revise all of the important drug classes for different systems, okay, relatively quickly. Now, one downside of these, that they're very big. And so I'm not suggesting, again, that you try to read them cover to cover at this stage, but to look up some areas that you got wrong, it's quite useful. And they're good for things like, how we make diagnoses and how things present. The only thing is for management, a lot of the guidelines have changed since they were printed, especially the 10th edition of the clinical medicine. That's due for an update now. It's been a good few years now. So if there's a specific guideline you want to look up, because the exam tends to use NICE guidelines as their reference point, you could look up the specific NICE, or NICE CKS is a summarized version of that. If you want to look at a lot of them quickly, what you might find helpful are clinical case cards, because we had lots of people who had that same issue of trying to cover lots of topics in a short time when they're also busy and they've got on calls, and they've also, for some specialties, got to put their portfolio together and things like that. So we've got 112 topic reviews. They're mapped to the same things that your exams are mapped to, and we update it regularly. So we're now on the 11th edition, which was published August 2023. So it's up to date as of now, okay? And it just makes it quick and easy to revise lots of guidelines for the clinical paper, okay? So there's a printed version, handy pocket size. You can look at it in between patients or on the tube if you're in London and you're commuting. There's a digital version, or there's a bundle that has both, okay? And then the mainstay of your preparation should be practicing questions. Ideally, realistic questions in the same format. So the eMedica MSRA question bank is the original question bank for this exam. It's been around since the exam's been around. We update it every year. We recruit doctors that have scored really well to write new original questions, but we map them all to the curriculum. Okay, so you've got concise explanations. We've got all of the same question formats that feature in the real exam. Our EMQs are one question per screen. They have a title just like the exam. There's 3 full clinical timed mocks. There's a full SJT timed mock. And then there's additional revision materials that you get sent, things to look up and read. In total, if you wanted to do all 2,200 plus questions once and read the explanations, it would need at least 100 hours of study time, okay? So, and you can see that they're mapped to the curriculum area. So each of these blocks has got 30 different questions. There's a whole nother section for mini mocks and timed full mocks, okay? So if you're going to go through, I'd recommend, let's say you do PEDS 1 first. Don't do PEDS 2 after that. Then do Neuro 1, then Derm 1, then Heme 1, then Obs and Gynae, then Psych. And this isn't all of it. It maps down. Basically, we cover all of the same topics that are covered in the exam. The reason that I recommend you do it this way is if you do all of the PEDS at the beginning, by the time you get to the exam, a couple of months later, you might have forgotten a lot of your PEDS. Whereas if you do PEDS 1 first, then Neuro, then if you don't have time to do everything, at least you've still touched on some questions and some topics from all the different curriculum areas, okay? And one of the things a lot of people have found helpful about the way ours is laid out is that they're grouped by topic area mapped to the curriculum and that the format is the same. So people have often said that it's closest to the exam if they've done multiple question banks, okay? And, that's a feedback we often get, that it's very similar, that there's good coverage, that the fact that it was split into different topics, they could structure it, gives you an easy way to follow the system, okay? And that it's sort of chunked into manageable numbers. 30 questions, including reading the explanation, you should be able to get through in about an hour, okay? So, one block each evening, for example, okay? Right, so I want to move on to the professional dilemma paper and practice some questions there. So this one, remember, in the exam will happen first. It's 95 minutes, and in that time, you're going to do 50 questions. Only 42 are marked. 8 are for research purposes. They won't look any different. Again, you have to take all 50 seriously. Timing is really important. The clinical paper's tight, but this one's even tighter, I'd say. And that's because it takes a much longer time to think about this, especially if you're less familiar with this. The questions in the SJT are split into 2 sections. About half of them are section 1, which are ranking questions, where you rank things from best to worst. And about half are selection or multiple choice questions, where you pick 3 things from 8 that go together. Okay. Now, although they're about 50-50 in terms of how many questions there are, in terms of marks, section 1 is about 2/3 or more of the marks. That's because each section 1 question is worth up to 20 marks. Each section 2 question is only worth 12 marks. Okay. And what this paper does, it's going to give you a work-based or work-related scenario at the level of an F2 doctor and test your decision-making and judgment by giving you some difficult situations or professional or ethical dilemmas. And what they're testing against are 3 core competencies: empathy and sensitivity, professional integrity, and coping with pressure. And for some questions, having a good working knowledge of core GMC guidance, ethical guidance from the GMC, can make it a little bit easier. So let's go straight into a sample question for section 1. So in section 1, you'll get a scenario, could be based in hospital, could be based in GP. And they will give you either 4 options or 5 options. So if there's 5, then 1 is the best or most effective option. 5 is the worst or least effective option. If there's 4, 1 is the best, 4 is the worst. Okay. If you want to finish just in time, you've got about 1:53 for each scenario. Okay. Today I'm going to give you a little bit less, and that's because one of the things you've got to do for this section 1, you've got to drag things into the right order. That takes a few seconds. So I'm going to give you about 1:50, and then I'll ask you what you think. Okay. Here we go. Okay, time's up. So type into the chat your order. While I give you a minute to do that, let me read over the scenario. And what I would recommend you do in the exam, you don't have time to come back to any of these. You want to finish the last SJT just as the buzzer sounds and give each one your best shot and give each one an equal amount of time. You don't want to spend too long on any one of them, okay? So as you're reading it, try to picture the scene. It will really, really help, okay? So you're just finishing a busy night shift, you're exhausted. Morning on-call doctor's called in sick. So you're just on your way out. Remember, you're exhausted. Now, every word is important in the SJT. So the senior nurse says, look, I'd like to speak to you. So look, you know what, medical staffing have said that, could you stay on until the early afternoon? Because, there's going to be a locum. They found one. Can you see, we can interpret that when a locum will be available. So they found one, but maybe they're coming from a different town or whatever, right? So they want you to stay until they arrive, the early afternoon. But look at this. There's being tired, there's being exhausted. You're barely able to keep your eyes open. You're unable to concentrate. Is it safe for a doctor in this situation to be seeing patients? Not just seeing patients, but carrying the on-call. Who does the on-call doctor see? They see the sickest patients, right? Patients who maybe, have gone off on the wards. They're going to call you to come and assess them first, or new admissions. Okay. So that's the picture and the scenario. And then if we look at the options, let's look at the preferred response. So preferred response is DAEBC. Okay, DAEBC. Now, if I look at responses that people have put, a lot of people have put A first. Okay, a lot of people have got AD EBC or AD and then another order, but a lot of people have got A as their first choice. Some of you have got D, and then quite a few people have actually got B as one of the higher ones and put D further down. A couple of people even put D last. Okay, so let's look at why. First of all, let me explain how it's marked. Okay, now if you had exactly this DAEBC, you'd get 20 marks for this, because it's got 5 options. There's 20 marks. If there's only 4 options, there's 16 marks. Okay, so because there's 5 options there, if you got exactly this, you'd get 20 marks. But if you get the answer wrong, depending how close you are to the best response, there's only ever one order. So DAEBC is the only order that will give you full marks, 20 marks. But for example, let's say you had A and D swapped around. You'd actually still get 90% of the marks. You get 18 for that. Even though you've got 3 right and 2 wrong, overall, ADEBC is still a very sensible order. Okay. Whereas you can see, if you had these 3 right, but you had D at the bottom and C at the top, you'd get a really low mark, even though it's still 3 right and 2 wrong. It's not just how many of you got right and how many of you got wrong. It's how close is your response to the best response. Every single possible combination has a number of marks keyed to it. That's why this is called keyed response marking. It's really complex. Okay. So even if you get it wrong, depending how sensible it is overall, you can get somewhere between 8 and 18. Even the worst possible order gets you 8 marks. But there's only ever one correct answer. Okay. So let me just show you first of all how you would actually do it in practice. Okay. And then I'd like you to think, those of you that put A first, type into the chat, why did you put A first? Okay. I'm just going to show you on our question bank. We've got the clinical questions here, the SJTs here. But I want to show you how you actually do it in the exam, because ours are in the same way. So you can see you've got a scenario here. You have 1, 2, 3, 4. You have your options, and what you do is you drag them. So you can see it takes a bit of time to do that. Okay. So you'd be doing that. If there's 5, there'd be 5 that you do. So you'll see there's some here, for example, where there's 5, some where there's 4. So you actually drag like this. Now, do you see that takes a bit of time? That's how you'll do it in the exam. You'll drag it like this into the right order. So you need to allow a bit of time to do that. Okay. So let's see those are people that put A first, why they put A first. Okay. So quite a lot of people have said the same thing, that they felt that A is quick and they want to do this quickly so they can start finding someone, and then they will go and find their boss, and to explain the whole thing is going to take a longer time. And so they're thinking about the impact of time there. Is there other people that were thinking along those lines, that you were thinking about these as an order of time? I would do this first, and then I would do this, and then I would do this. Is there anyone else that was thinking along those lines? Yeah, quite a few people. Okay. And so this is the most common reason to lose marks in section 1 questions, is when people think about it in completely the wrong way, in that they misunderstand what the question is asking. It's that they think, I would do this first and then I would do this. Each option in a section 1 question is discrete. The key thing is to think or, not then. You're comparing to the one above and the one below and imagining that this is my whole answer to the situation. If I could only do one thing, and that's all I'm going to do, I'm not going to do anything else, which one is the most complete? Mapping back to those domains. Okay. So if I could only do one, which is the best one? Is it this, or this, or this, or this, or this? Not, I do this first, and then I do this, and then I do this in a sequence of time. If you think about it like that, you're regularly going to lose marks in section 1. Okay. So if we go back, remember the domains: empathy and sensitivity, professional integrity, coping with pressure. So part of this is knowing your limits, knowing when to ask for help. Okay. So can you see that the reason that D is the best response is the most complete? We all agreed that it's not safe for a doctor in this situation, barely able to keep your eyes open, exhausted, to be seeing patients. And so can you see, if you discuss the situation, that means the whole thing, with your consultant and explain why you feel it'd be unsafe. It's clear that you're not staying on, that you recognize it's unsafe, but you're also explaining the situation. Look, the locum hasn't turned up for the morning. They've asked me to stay on. I don't think it's safe because I've just finished a night shift and I can't concentrate. They have got a locum though. Well, part of your role as a junior doctor is to let the senior team know what's going on. For example, they could then allocate the registrar, look, you better carry the bleep until this locum comes. They can't stay on. I've got the clinical. It might be inconvenient, but it's not unsafe as it would be for you to see patients. Okay. But you see that this also highlights part of professional integrity. One of the subdomains is that you challenge inappropriate behavior. Medical staffing know they shouldn't ask someone who's just finished a night shift and exhausted to stay on. Not only is it unsafe, but actually you breach the working time regulations on how many hours a row you can work when part of that is in the night. You have to have mandatory rest. Do you see? So if you're only going to do one thing, this one shows that you know your limits, that you're also highlighting that you think you're discussing the whole situation, what's happening, that you recognize it's not safe. And by letting someone senior know, they can liaise with other people like a registrar to make sure that there's appropriate cover. But you can see, if all you do is this one, not this, then this, if this is all you do, you've said, look, I'm not going to do it. Your boss doesn't know necessarily that they've got no cover, so they can't make any arrangements. They're probably asking you, knowing that you've done a night shift, because there's no one else. And that's why they've gotten for an external locum from somewhere far. There was someone available locally, on site within the hospital grounds. That's much easier, isn't it? Okay. However, this is the next best option in that it still recognizes that it's not safe for you to stay on. All right. Now let's look at this. Say that you're too tired to work at the moment, but we'll be happy to come back in the early evening prior to your night shift to help out. Now, some people thought this sounds really helpful and they've put this near the top. There's still a risk here. What's the risk? First of all, coming back in the early evening, they don't need you. The locum's there now. But if you're coming in prior to your night shift, what's going to happen towards the end of your night shift when you're now worked over the maximum night hours and you're really tired and that the locum's gone home? You might be overtired and put patients at risk. There's risk attached to this one. And they don't need you coming in at this stage. The locum's there. Okay, now we're left with the B and C. B and C are the worst options because at least with this one, you'll have got some sleep before you come back, okay? And then you might be tired towards the end, but you're definitely exhausted now. Both of these, you're staying on when you know that you can't even concentrate. There's being tired and there's, when you're dropping off, okay? So both of these show a negative for knowing your limits, which is one of the subdomains, okay? And so what separates them? Why is C worse than B? Because remember, these are comparative. Is it better or worse than the one above and the one below? That's what you need to be thinking about. And to remember, it's or. If this is all I'm going to do, I'm not going to do all of these. If I'm only going to do one, which is the best one, that's what goes number one. So what makes C worse than B? In both of these, you're being unsafe. What makes C worse than B is what the guidance is in how to approach SJT is to pick the answer that a good doctor should do, not necessarily what you would do, okay? And there's guidance that, like if, for example, they needed a locum and it's planned, they know someone's going to be away on the next bank holiday and they're asking you in advance, will you cover this? It's absolutely fine for you to ask for locum rates, or if they can't give you locum rates, give you, like extra time off, okay? But GMC guidance says that if you're going to help out in an emergency, you shouldn't try to take advantage of that situation, okay? Watch this. You're saying, look, I'll do a few hours. Here, you're saying I'll do a few hours. What you're saying here is, but I want a full day. So I'll do 3 hours, but I want you to give me 8 hours back. You're trying to take advantage of the fact that they're stuck. That's considered unprofessional, okay? That's why C is worse than B. So that's why the best response is D, A, E, B, C. So two big things I want you to remember, that it's or not then. You're not doing all of these. You're only going to do one of them, which is the best one. They're discrete options. It's not a sequence of time. I do this, then this, because if you think like that, you're regularly going to lose a few marks. The other thing is to compare. Okay, that's really, really important. Okay, let's do a section 2 question. So section 2, you get a scenario just like section 1, but it takes much longer to read because there's 8 options, not 4 or 5. Here, you're asked to pick 3 options that taken together make the most appropriate combined response. Okay, so remember, section 1 is or, section 2 is and. Okay, think I do this and this and this together. That's my response. That's how you need to approach section 2. Completely different mindset. Here we go. Great, that's time. You can actually select, I've launched a poll, you can actually select all 3. And that's how it is for this type of question. You just tick, you're not ranking them first, second, third, you just tick the 3 that you want, okay? Again, if I'll just show you on our SJT how it looks, because it's how it will look in the exam. For selection ones, it's just like this. You've got the scenario, you've got your options, you just tick the ones that you want. Can you see you're not ranking this is first, this is second. You're not saying which order, you just tick them. That's how it is in the exam. Okay. So very interesting. In terms of what people have picked, the most popular answer by a big margin is H. Okay. And then after that, there's quite a lot. Every single option has been picked, by the way. Okay. But quite a few of you have picked B. More than half of you have picked D. Quite a few of you have picked G, quite a few of you have picked E, okay? So quite a lot of different options have been picked. So let's, again, read the scenario back. So you've been treating this patient who's diabetic, and he's on the care of the elderly ward. He's 68. He's had a fall. I can see, there's some things you can logically deduce when you're reading these. The fact that they are actually on the ward, it must have been a significant fall. Do you see? Because a lot of falls will just treat them in A&E, manage them in the community. But they've needed an admission. And you notice that they're having an unexplained spike every evening before dinner. You expect it to go up after dinner. And he's talked about sweets. You've seen his wife who comes every afternoon. She's bringing him some sweets as a treat. Okay, so let's look at the options. So the preferred response is B, G, and H. B, G, and H. Now, the way these are marked is binary. Basically, you get 4 marks for each bit that you got right. So if you've got all 3 of those, B, G, and H, you get 12. You've got any 2 right, you get 8. You've got any 1 right, you get 4. There's no negative marking. So, the fact that you got some of the others wrong, you don't get the 4 marks, but you don't lose the one that you got correct. So, if you get 2 right and 1 completely wrong, you still get your 8 marks. Doesn't matter how wrong the third one was, okay? But the key thing here is that it's the most appropriate combined response. Think and. Read it back together, add in the word and ask yourself, does it make sense together? Would it work logically? Because there can sometimes be options that are sensible on their own, but together they don't make sense. And you can only pick one from those options, okay? And with section 2, very different approach. Remember, section 1 is this or that. It's better or worse. You're comparing. With these, you can actually look at some options and decide these clearly go against some kind of GMC guidance, or they clearly show a negative for empathy and sensitivity or professional integrity or coping with pressure, and therefore I can eliminate it. Okay, so first of all, let's look at the ones where there's something clearly wrong with it and eliminate them. And that sometimes makes it a little bit easier, because then you might be picking 3 from 5 or 3 from 6 rather than 3 from 8. So we can get rid of A straight away, right? The word confront. That to confront a patient who, by definition, if he's admitted into hospital, is vulnerable, is unwell enough that he had to stay in hospital. So to confront them about his wife's behavior, that shows a big negative for empathy and sensitivity, doesn't it? And also for professional integrity, okay? So A is the one that's really easiest to get rid of, okay? C also is quite easy to get rid of. That monitoring their blood sugar levels less frequently. If it's unexplained, if we monitor it less frequently, it might get even worse and would just take us longer to know about it. So this isn't thinking about the patient's best interests. It might make less work for you, but it's not thinking about the patient's best interest, okay? Option F, why is that inappropriate? What's wrong with option F? Type into the chat. So option F, there's two things about it. The first is that this patient, while it might not be doing his sugars much good, he might get a lot of benefit in his overall well-being to have his wife come and visit him every day. Got to think about their mental well-being, got to think about everything else. That's one thing, okay? But the second is actually really important. Part of professional integrity, coping with pressure, knowing when to get help, knowing your role in the team, and what you can. This is just not something you have control over. This is going beyond your limits. This is not something that's the role of a junior doctor to decide who can visit how often. That's something that the ward manager might decide. Do you see? So this is just not your role. It would be unprofessional for you to suggest something like this, but also it might be overall to the detriment of the patient's well-being. Okay, so there's a few we can get rid of because there's something clearly wrong with them. Now we're left with the slightly more challenging ones. Quite a lot of you picked D, quite a lot of you picked E. What's wrong with D? What's wrong with E? It's the same thing, but what is it? Great, well done. Confidentiality. Okay, both D and E constitute an inappropriate breach in confidentiality. So they go against GMC guidance. Okay, look, while his wife is visiting, you drop by and discuss his care and recent results. You haven't, in any of the other options, got his permission. If there was an option, seek Mr. Jackson's consent. Let's say option A was seek his consent, and you added that to this, then it might be okay. But as there isn't an option here where you've done that, his results are private. He might be happy to have his wife come and visit him, and they talk about, what Netflix show he's been watching because he's got a lot of time. Okay, but you see, as she's already there, and you start talking about this, you haven't got his permission. That's very different to if he came to clinic and he bought his wife. Do you see, there's an implied consent because he's an adult, he's got capacity. If he didn't want his wife to know, he would have asked her to wait outside. She's already there. You've not sought consent and you've just started talking about it. This would be inappropriate breaching. And same here. While you might have good intentions, discussing his results with his wife without any of the other options, you've sought his consent. Just because his wife gives him no automatic right, this would be, again, an inappropriate breaching consent. In confidentiality. So this is where knowing the GMC guidance. When could you breach confidentiality? If doing so might prevent the patient from death or serious harm. That's not the case here. His sugars are a bit high. Do you see? So this is not a valid reason to breach confidentiality. Now, the litmus test. How do you know you've got it right? Section 2, even before it's marked, you can know you've got full marks for every question. All you need to do, read back your 3 choices together, add in the word and think, number 1, does it make sense? And number 2, does it show positives for those domains and deal with the situation as best as possible? It's not always going to be in alphabetical order. Okay, but look, does this make sense? Okay. I'd do H first. Discuss the recent blood sugar levels. Mr. Jackson, your sugars have been a bit high. Let's explore, not confront. Let's explore. Just it'd be helpful. Talk me through, what did you have for breakfast yesterday and lunch and dinner? Any snacks? Okay. And, well, look, as your sugars are a bit high, these are some sugar-free treats that you might enjoy. They might give you that taste that you want, but they're not going to affect your sugars because they actually haven't got sugar in them. Unlike, what you've just told me when we've explored your diet, that you've been having these sweets. And continue to monitor his blood sugar levels at least daily. Does it make sense, first of all? Yeah, it makes perfect sense. That's how you know that it could be right. And then, does it show positives for the domains? It does. And so now you know you've got it right. That's how you're going to get 12 out of 12. So how to prepare. The first thing is to know the domains, and each domain is broken down into subdomains. If you know and understand those, that will really help. Have a good understanding of good medical practice, and we're still using the old version of good medical practice. Some of you might be aware that Good Medical Practice 2024 has been published in draft format. It doesn't go live and won't be used in exams until after the end of January 2024. So for this exam, we're still using this version of Good Medical Practice. Okay, the 2024 guidance will come into place from round 2 onwards. Okay, and apart from Good Medical Practice, the core GMC ethical guidance. Understand the difference between section 1 and section 2 questions in terms of approach. Section 1 is or, section 2 is and then practice questions ideally to time. And then learn the biomedical ethical principles. Learn when you can and can't breach confidentiality. Learn about capacity and advanced refusals and do not attempt resuscitation orders. Gillick competence, the Fraser guidelines, consent, Bolam, Montgomery, Bolitho, the GMC guidance on that. Personal beliefs in medical practice and conscientious objections to certain things. Financial issues, when you can and can't accept gifts, raising concerns, safeguarding. Okay. Now, you can read all of this stuff on your own. If you want to cover it all efficiently, we do have a 2-day MSRA grammar course. And if you found the sort of teaching that we've only covered a few topics because we only had like an hour. Okay. But we have 2 full days. Day 1, full day on clinical. We'll go over 130 topics. There'll be a full-time clinical model. Day 2, SJT will cover all the key GMC and ethical guidance. Big focus on exam technique on both days, the key words and how to understand them. We'll cover high-yield clinical topics, quick way to revise lots of up-to-date guidelines, okay, efficiently. We'll cover all of the key ethical guidance that you need for the SJT in the second day. And there's time teaching walks with detailed explanations so you understand why and how can I get those few extra marks. We've been running this course and had excellent feedback for over 16 years, and all the questions in the grammar course are unique. If you book the 2-day course, you will also get access to the recording for a month afterwards for a revision, and it includes access to the question bank with 2,200 questions. So, if you were to book the 2 days separately and the question bank separately, it would cost you £150 more than if you book the whole thing as a bundle. Okay, so it's the 25th and 26th. The 25th is clinical. The 26th is the SJT. It is possible to just book 1 day. Some people just want help with the SJT. Some people just want help with the clinical. So I'll show you on the eMedica site. We've got a section for MSRA. It's right at the top, and it's the top option. Okay, so the 2-day course plus the online plus access to the recording. You get access to the questions up until the end of January. So it'll cover you whichever date you eventually get allocated. But if you just want to book the clinical, you can. If you just want to book the SJT, you can. You then need to book the online separately because they're not included if you book just 1 day. But if you book the full 2-day course, you get all of the questions included. Okay. And again, we've helped people for pretty much all of the specialties, ophthalmology, CST. This is the recording. So you get access to the recording afterwards of the updated recording. This doctor ranked 2nd in the whole country for psych, 5th in the whole country for GP. Got their first choice CAMS offer in London, GP offer in London. She accepted CAMS. This doctor, they improved their score from 552 to 625. They hadn't got into anesthetics, improved their portfolio as well, didn't give up, and then came back, smashed this, then smashed the interview as well. This doctor was particularly worried about the SJT, and that's why they came to get the SJT teaching. They got one of the top scores, ranked in the top 20 in the whole country in GP. Again, a lot of people find the sort of exam technique and the concise teaching helpful. This doctor, amazing. They ended up getting offers for radiology, GP, psychiatry, and obstetrics. 4 offers in round 1 last year. Okay, so I'm going to talk about how to prepare effectively. I've talked to you about some of the resources that will be useful, but how to then use that. And I'll combine that. We've been teaching and helping doctors for many years now. And we often have people who maybe didn't get quite a high enough score for the job that they wanted, or didn't get through to interview. And we're often helping people resitting. Also get some people who just want to do as much as they can the first time so that they don't have to repeat. Over the years, we've done some research ourselves and looked at what are some of the patterns that we see in people that don't quite get the score they want, and how can you avoid them? The first is not allowing enough time. So you've got doctors that sort of find out the timelines, and have already been preparing for a couple of months at this stage. Then you've got doctors that now that they are applying, they realize this is the process, and maybe they're starting, like some of you, today is your first serious doing some questions and thinking about this, okay? Okay, that's not as good as someone who already started it a couple of months ago, but then you've got some people who will wait until after they've got confirmation they've been longlisted, i.e. they've submitted and they've not heard that there's a problem with their CREST or their competencies, and they think, okay, now I'm confident. Then you've got people who wait until they get the actual invitation, which is middle of December. By that stage, they've got 2 weeks, okay? And so, even if they're already got a good background knowledge, if they've got some busy shifts and, people have family things over Christmas, New Year's, what they might find is they might still be able to work really hard and get enough to pass, but it might not be enough to either get an interview or get a job or get the job they want. They might get their 200th choice, not their first choice. So first thing is to plan ahead, start early, and be consistent. Do something every day, okay? For those of you that haven't already started, just look, you've started today. From tomorrow, every day, do something, okay? The next is underestimating the exam. I think sometimes people underestimate the time because the curriculum's large. But I think the other thing that they do is they underestimate how competitive it is now. So what happens is people talk to their friends, and their friends, for example, applied for GP and they said, oh yeah, I got a score of 410 and I still got a job. And that's because they were applying 3 years ago, when that kind of score, even last year, that wouldn't have got you a job anyway. If you put down every single place, that wouldn't have got you a job, okay? And I think a lot of doctors, they're not doing it intentionally. They're just not keeping track because it's not important to them, the levels of competition. They're already in training. They're not aware how much the number of people applying and therefore the competition ratios for every single specialty that uses MSRA has gone up in the last few years, but especially the last 2 years. The numbers have gone crazy the last 2 years, okay? So I think it's really important to understand that just passing isn't enough for most specialties to get an interview or to get a job. You need to get the best score possible. Focusing on just one paper. So sometimes people forget that both papers are equally weighted at the initial stage. So like if you do brilliantly in clinical but fail the SJT, no matter how good your total score is, for a lot of specialties, that's a fail overall. You won't even be ranked. You'll have no chance, even if your total score is good, okay? Some doctors, it's the other way. They're naturally really good at the SJT, but they don't allow enough time for the clinical. Maybe they've been working in one specialty for a long time. They haven't read or, had to manage some of the patients and cases for some of the other topics in the curriculum for years because they've been doing one specialty for a long time, okay? And finally, poor exam technique. So sometimes people have got the knowledge, but maybe they misunderstand the keywords. They're not good at managing their time. They don't finish. They're not confident or don't know how to approach the different types of SJTs and map them to the right domains, okay? So how to prepare effectively? It's really, the opposite all of that, but just some specific things that you can do. You want to have a good mix of active learning and passive learning. So the bulk of your time at this stage, we're 2 months to the exam, aren't we? Okay, is doing questions. You should be doing some questions every single day. Read up the explanation for any that you get right. Any you get wrong, beyond that, maybe read the relevant guidelines. You get a deeper understanding. You want to have a way to cover the curriculum systematically. So, if you're using our online questions, as I mentioned, they're mapped to the domains in the exam. So just go through and make sure you cover them all. Try to not let a single day, and I know there'll be days where you have a horrible shift and you're exhausted. I have some clinics where I'm exhausted by the end of it, okay? Because just, you can't predict what happens in GP, okay? And actually I work as a GP in a secure unit for women with significant mental health illness. So sometimes, we've got things that just completely out of the blue, it takes a long time, okay? But you've got to make those sacrifices now so that you get the interview, get the job that you want, and it'll be worthwhile after that, okay? So look, even if you're starting now, if you wanted to do all 2,200 questions on the eMedica question bank, that will take 100 hours of study time. So if you did an hour and a half each weekday, you don't have to do it all at once. Get up a bit early, do half an hour before you go to work. Do 10 minutes on your phone, during lunch break, do a few more questions. Finish it off when you get home, so that you've done something, okay? Maybe read a couple of topic reviews on the case cards. And then if you then double up 3 hours a day on Saturdays and Sundays, there's 4 weekends between now and the start of the exams. If you were to do that, you'd just about get to 100 hours. You'd be able to just about finish. Practice realistic questions. That's going to help you to work on your exam technique because they're the right format, they're appropriate level of difficulty, they're worded in the same way. But as you get closer, try to do the last couple of weeks before the exam, you want to make sure you're doing some timed mock exams to get used to your time management. By that time, you've covered a lot of the material. So you get a good benefit from the mock, and it'll help you identify the last few gaps to fill in. Then find a study partner, a single study partner, or a very small group, like 2 or 3 people. What doesn't tend to work well, as I've seen in my experiences, sometimes people will join a massive WhatsApp group where there isn't that accountability, and you just get lots of people asking, how do I book? Or, are the applications open? Or people that aren't even at the point of applying that, what's the eligibility for this? They're not actually seriously studying. What you want is 1 or 2 people, and you say, look, today we're going to do PEDS 1. And any that we're not sure, let's discuss them. And then you have accountability, okay? Within the groups, they're going to post, okay, you've got to have it done by this time, right? Have you done your questions, all right? That works really, really well if you can have a study buddy or a small group, 2 or 3 people, not hundreds, okay? And we do have, if you want to find a study buddy, we've got an MSRA support group, which is for any of the specialties that use MSRA. If you're applying for GP training, we've got a much larger group where there's also GP trainers, educators, and trainees in every level, where if you've got specific questions to do with GP, we've got the GP training support group. Someone will post links for both of those. You might find that helpful. And then, as I mentioned, we've got 2,200 questions. It will take you 100 hours to cover all of those if you were to start now. If you've already made a start, great. Keep going, keep pushing. And then the 2-day crammer course. If you want to be able to, if you've left it late and you want to cover a lot in a short time, or you're applying for something really competitive, or you're applying for GP and psych and you want specific areas, and so you want the best score possible, you don't want to be on the waiting list and have to be left with whatever's no one else wanted or got rejected by other people, it might not be one of your top choices, then there's 2 full days where we can help you by covering a lot of ground in a short amount of time. And then you can watch the recordings again to revise it, okay? And then that includes the questions, all right? So, oh, by the way, just to follow up, remember that doctor got 552 the year before, got 65 this last year, and they got their anesthetic interview, got this follow-up email from them. They ranked 6th in the country after interview. They got their first choice anesthetic jobs in the Royal London, okay? Right, so that's it really. I just want to summarize that before we go, do join the MSRA support group if you're doing any of the other specialties, the GP training support if you're doing GP. And if you want to get access to this recording, but also on our YouTube channel, we've got videos on how to actually navigate and find specialties on Oriel, how to make sure your competencies are accepted, frequently asked questions about the MSRA. There's loads of videos that you'll be able to find on our YouTube channel. So please do have a look there. But just to summarize, look, it's a 2-part assessment. It's equally weighted in the initial phase, okay? Whether you get shortlisted or not for those specialties that interview is about MSRA. They're only going to shortlist the top scorers, okay? But in most cases, it will then also carry over and play a small proportion in the rank. For GP, Psych, CAMS, 100% of your rank is based on your MSRA. And remember, it's competitive rank. Sometimes even 1 mark can make a difference. That could be the difference between getting your first choice job and your second choice job, or being the last person to get a job and not get a job in any of your choices. You see, so even 1 mark can make a difference. So just passing, because almost everyone that sits MSRA passes, just passing isn't enough in most cases to get an interview, and may not be enough to get a job for those specialties where it's just based on MSRA. So what you want to do, focus your revision, practice under time conditions, use those things. And I'll leave you with these 2 messages. That to succeed, we must first believe that we can. Sometimes people look at these competition ratios, these numbers, and they think, what? It's horrific now. I've got no chance. If you think like that, what happens is the minute that you have a tough day, forget it. I'm not going to get in anyway. I won't study. Or you don't do well in 1 block, and it might be something you haven't done since medical school. And, and no wonder we all have things that if you're not learning it, you're not reading it, you forget, right? If you have a negative mindset from the beginning, you'll give up very easily. And it becomes a self-fulfilling prophecy. But look, someone's going to get that job. If you decide, look, I can do this, and start with, I will get shortlisted, and I'm going to get my first choice job in my first choice area, then you can work towards that. Because that brings me on to what Malcolm X says. The future belongs to those who prepare for it today. That if you decide that, look, I'm going to do it, right? And then you just absolutely go at it and put everything you've got, put in the hours. Someone's going to get interviewed. Someone's going to get that job. Let it be me. You see, then even if you're busy, you think, I've got to do it. I've got to put in an hour. I've got to do 1 more batch of questions. I'm going to read 1 more guideline. I'm going to review a few more topics, okay? And then it will happen. You will make it be, all right? You will get that interview, you'll get that rank that you want. You see, aim for 600 plus, then even if you have a few bad days, you're still going to get enough that you get the interview that you want, that you get the job that you want. Whereas if you're aiming for the absolute minimum to scrape through, and then the competition increases a bit more than we're expecting, and you have to have a couple of bad shifts, you might not be enough to even get the interview. You see? So look, start with a positive attitude, and then you know what to do. You know what to expect now. Just do the work. Put the hours in. Keep pushing, keep going, prepare, and you will succeed. And I'd love to add you to the list of people come the results and get those emails that you've smashed it, you've got your first choice job, it's the rotation that you want. It's, these things make me so happy. It's why our whole team stays passionate and continue to be involved in medical education 18 years and 75,000 delegates later. Okay, so I hope you found this helpful. For those that haven't got questions, thank you so much. All the best with your preparation, with your application, with your exam, and with getting the absolute first choice job that you want. Okay, nothing makes me happier than to hear your success stories. I don't want you just to get a job. Don't settle. Get your first choice job. Go for it. Okay, so thank you so much.